Hi everyone, this is Dr. Deeksha here. So I'm going to bring to you a two-part series on lymph node pathology. This is mostly for postgraduates to understand how to approach the lymph node pathology, but of course here and there are some small nuggets for MBBS students and those appearing for PG entrance exams. Now the basic outline I'm going to take in these two videos will be, we'll discuss the normal lymph node structure. We'll also discuss a checklist while assessing, describing, or reporting, and this is going to prove very useful for postgraduates. We're going to see the patterns of reactive lymphadenitis, infectious lymphadenopathy, inflammatory lymphadenopathy like Kikuchi, Kimura, and Castleman, the more common ones that you're going to come across, neoplastic lymphadenopathy, and metastatic lymphadenopathy in terms of carcinoma of unknown primary and the IHC approach to it. And then I'm going to summarize all of them. Now in this part 1, we're going to discuss the first 4 things, and I would suggest right about now for postgraduates to start taking some notes. Now lymph node will have a capsule. So there's your capsule. It'll have afferent lymphatics, the subcapsular sinus, the efferent lymphatics, the sinusoids, the medulla, and then you will have the cortex, which will contain the primary follicles and the secondary follicles. The follicles that you see now are homogeneously colored, so those are primary. And then when they are stimulated by the antigen presentation, you will get a germinal center and an outline of mantle zone, which is the secondary follicle. The green areas that you see now that I've just schematically drawn as green are the areas between the cortex and the medulla, and that is the paracortex. So if we were to identify, we have the capsule here, the afferents, the efferent, the sinusoids, the subcapsular sinus, the cortex, which has the follicles, and the medulla, and in between you have the paracortex. This is a better schematic, a non-animated schematic. Here again, one by one, let's revise the structure of the lymph node. You'll have afferent lymphatics, the efferent lymphatic, the marginal or the subcapsular sinus, the cortex, which mostly contains B cells in the form of the follicles, the paracortex, which is T cell rich area, the medullary cords, which are rich in macrophages and plasma cells, the medullary sinus, which you can see is continuing with the sinusoids, and this is the primary follicle. If you'll recall, I had told you that it will be homogeneous, and this is the secondary follicle, which has an outline of mantle zone. So you have an outline of mantle zone, which is darker, and the inner area, the lighter area, is the germinal center. Now within the germinal center, you will see a lighter zone, which is mostly centrocyte. See, very simple if you break down the word, center, site, cell, so the cell of the center, so lighter zone. And dark zone of the germinal center are mostly centroblasts. Again, break down the word, you have center, and blasts, which means premature, immature forms of those cells. So sites are the mature forms, blasts are the immature forms. In this photograph, which is an actual lymph node histology, you can see that this area is the cortex, and you can see the medulla in the center. So what I've marked here are the secondary follicles. Now, if you were to look closely, you could make out that they all have a darker outline, which is the mantle zone, and the inner lighter area, which is the germinal center. And if you can focus a little more on the germinal center, you'll be able to see that there are darker areas and lighter areas. There are darker areas and lighter areas, darker areas, lighter areas, which tells us that these are normally proliferating or normal secondary follicles. This bluish merging area between the two is the paracortex, and here this is the medulla. So that's your basic identification of the different parts of the lymph node structure. Next, I'm going to talk a little bit about what are the patterns of reactive lymphadenitis. Before that, let us talk quickly about what are the parts so that we will know what are the patterns of reactive lymphadenitis affecting each part. So first, the cortex. So primary and secondary follicles, which are B cell rich, are clearly going to be positive for the B cell markers, these three. Now, when we talk about lymphomas, especially B cell lymphomas, it is very important to mention this marker for the simple reason that we have targeted therapy. I'm sure all of you have heard of rituximab. So our clinician, the consulting clinician, would want to know CD20 status. Germinal center or B cells, Here also has B cells, and the B cells will be positive for the usual markers, but more importantly here you'll see two interesting markers, CD10 and BCL6. Now BCL2 is normally negative. Remember, it's an anti-apoptotic gene which is switched off here. Okay. In the mantle zone, it is switched on. So mantle zone cells are BCL2 positive. Please remember, this is the normal pattern. In the paracortex, the cells are usually rich in T cells, and that means they'll be positive for CD2, CD3, CD5, and CD7. These are the usual T cell markers. Of course, the most important one is CD3 because it's a part of the T cell receptor. Very, very useful in identifying a T cell population. Now, the normal ratio of CD4 to CD8 within this area is 3:1. In the medulla, we will see plasmablasts and plasma cells, and they are positive for CD38 and CD138, and because it's a polyclonal population, both kappa and lambda light chains will be present. This is important. Why? Because anytime there is a monoclonal population, you will only see one of them. In the lymphatic sinuses, if you trace them from subcapsular, cortical, and medullary area, like I said, very importantly, macrophages will be present, and these macrophages are CD68 and S100 positive. So with this table, I wanted to cover the parts, the composition, and the immunohistochemistry markers for each one of them, which means that if there is a condition that has involved, think about it, B cells, you will get a cortical hyperplasia. If you have a condition that has involved T cells, cause proliferation of T cells, you'll get a paracortical hyperplasia. And if there is something to cause a proliferation of macrophages, you will get an expansion of the sinuses. So if you can remember these three patterns, now let's look at the actual photographs. But before I show you the photographs, I want to quickly give everyone a checklist for when we have enlarged lymph nodes. Now, enlarged lymph nodes or lymphadenopathy can be approached in two ways. First, let's look at them clinically. Clinically, what are the things you should know about enlarged lymph nodes? Whether the lymphadenopathy is localized or generalized. What is the size? Usually anything more than 1 centimeter worries us, and that if you have a general group of lymph nodes which seem expanded, we try to biopsy or do an FNEC in the largest and the most accessible lymph node seen. The consistency is important, as I'm sure you remember. A firm, rubbery consistency could point to a lymphoma, and very hard lymph node could point to a metastasis. Tenderness is also very important. Why? Because although this is not a hard and fast rule, but a non-tender lymphadenopathy worries us in terms of it possibly being a cancer involvement. And if it's fixed, again, as a rule, I'm sure all of you know, fixed, any mass points to a possibility of a malignancy. But coming to the pathological points, and this is where I want all the postgraduates watching this to pay attention. When you want to start describing a lymph node pathology, what are the points to keep in mind? First, let's start from the outside. Mention what's the status of the capsule. Is everything fine there? Then have a look at the architecture. Can you make out the usual cortex and the medulla? Is any part expanded or is any part effaced? Effaced means you can't see it as clearly. It's lost as architecture. If it is expanded, look at what part looks expanded or which part is expanded the most. Is it the follicles? Is it the paracortex? Are they the sinuses? If it's effaced, then you need to pay a little more attention in terms of, is it partially effaced? Is it completely effaced? Is it effaced by nodules or is it effaced by sheets of something? So is it nodular or is it diffuse? Is it, if the effacement is there, is it by a cell population which looks mixed or which looks very homogeneous or a monomorphic population? Whatever is effacing the lymph nodes, are those cells small, medium, or large? We use a small lymphocyte for comparison. Then we should mention whether there's necrosis or not and whether there are granulomas or not. So this list over here is extremely important for every pathology resident to bear in mind when you start looking at lymph node biopsies. Now, this is to tell you what are the different reactive patterns. So you can see the black cells, the tumor cells, metastatic cells entering through the subcapsular sinus going into the sinusoid. So they'll expand the macrophage population. Then the second pattern could be reactive follicular hyperplasia. So you'll see lots of follicles taking over the entire lymph node, secondary follicles, of course. Then the third pattern could be something causing T cell expansion, which would expand the paracortex, which would make your follicles disappear. So remember, there are three broad patterns of reactive lymphadenitis, depending on what part of the lymph node they are affecting. Are they affecting the sinuses, which is called sinus histocytosis? Are they affecting the cortex, cortical or follicular hyperplasia? And are they affecting the paracortex, so paracortical hyperplasia? Let's look at a couple of photographs. Now I will label this for you. See it with me. You can see fat here, right? You can see a couple of blood vessels. This is a fibrous capsule and this is the lymph node. You can see the blue lymphocytes. Now within the capsule, I'm sure all of you can make out that there looks to be an abnormal population entering in, right? Can you make this out? This looks worrisome to me. So the subcapsular sinus is where we start searching every time you send us a lymph node biopsy, a sentinel lymph node biopsy looking for metastasis. This is where they'll start and this is how they'll go in. This is another photograph. You can again see a lot of fat here, a couple of blood vessels, the capsule. And you can see that here within the capsule or in the subcapsular sinus, there seems to be nests of cells, right? Immediately you can make out that they have abundant cytoplasm. That's why they are pink and they look abnormal than the rest of the lymphocyte population. So you can see this has gone more further in, right? So again, this is an example of metastasis. Here, if you look at this photograph, you can see the fibrotic capsule, the lymphocytes, and here where the sinusoids should be, there seems to be a proliferating macrophage population. Now, this is called sinus histocytosis. We will talk a little more about different types, but as a reactive sinus histocytosis, this is a sign that something has come within the sinusoids. So you can see this kind of pattern in a metastatic lymph node. That's just one example, but along with the abnormal cells, you can also make out a sinus histocytosis. Now look at this lymph node. You can see fat here. This is the capsule. You can see a couple of blood vessels. And if you notice, I cannot really make out just a very normal cortex or a normal medulla. There seems to be varying sizes of follicles that seem to have sort of taken over, the entire lymph node. And you can see germinal center, mantle zone, germinal center, mantle zone. And within the germinal center, you can see some, empty white spaces from a distance. Those are actually tingible body macrophages. Those are macrophages because it's a very high proliferating germinal center which is expanded, and this is an example of follicular hyperplasia. Follicular hyperplasia, a B cell expansion. Now look at this photograph. You can see a capsule here, one lymph node, another lymph node, and here see, you can see like a follicle, half a follicle or a bit of a follicle seems to have merged with the rest of the population, which means the paracortex has expanded. What has expanded? The paracortex, which means that this is a case of paracortical hyperplasia, which means T cell expansion. So these were the different patterns of reactive lymphadenitis. Next, let's go to lymphadenopathy classification: infectious, inflammatory, neoplastic, and metastatic. So an organism, an inflammatory condition, neoplastic, which means lymphomas, and under metastasis, again, I will say a carcinoma of unknown primary. We are first going to talk about infectious lymphadenopathy. And under infectious lymphadenopathy, we can talk about a couple of organisms: viral, bacterial, mycobacterial, because this is where granulomatous inflammation comes in, fungal, of course that also has granulomas, and protozoal. First, let's discuss a couple of important viruses. The first is Epstein-Barr virus. Now in Epstein-Barr virus, remember the triad given is of fever, pharyngitis, and cervical lymphadenopathy, and of course the monospot test will be positive. So these are the clinical features to look out for. Now since it's a viral infection, T cells are what will expand. So T cells mean paracortex, which means there you will get expanded paracortex. There could be mild follicular hyperplasia, and don't forget that you can also get RS-like cells. These are reactive cells, nothing to worry about. Don't call it Hodgkin. These are RS-like cells. Now, as a cytopathic effect in the peripheral blood smear, you'll get Downey cells. Now, what would they look like? You can see lymphocytes here with abundant cytoplasm and a bit of bluishness to their cytoplasm, right? This abundance is called the ballerina skirt appearance. And here you have a couple of more lymphocytes. You can see bluish abundant cytoplasm, little spread out like the ballerina skirt. So these are all examples of Downey cells. Downey cells are reactive T lymphocytes seen on the peripheral smear. Next is cytomegalovirus. Now, cytomegalovirus in immunocompromised patients can give rise to a severe disseminated disease, especially in transplant-like cases. So you have to remember that scenario in the clinical history of a transplant patient. But in immunocompetent patient, usually the picture is acute flu-like. The picture is acute flu-like. Now again, since it's a viral infection, what you're going to get an expanded paracortex. Similarly, mild follicular hyperplasia and RS-like cells. As far as the cytopathic effect goes, you will get large, very important. Don't forget it's called cytomegalo for a reason, right? It's called cytomegalo for a reason. And the inclusions are deep purple, which means basophilic, right? They are basophilic, quite dark intranuclear inclusions, and they have a clearing around the inclusion. So this is very important. You'll see a clearing around the inclusion, which is why it is said to have what we call an owl's eye appearance. So look at these inclusions here. This is the inclusion. You can see a perinuclear clearing, right? You can see the nucleus and there's a clearing around the inclusion. You can see lots of them, and this is why they are called an owl's eye appearance, right? Very small note here. There is a tendency I've noticed when I've discussed this with students, they'll say they'll mistake this. They'll say this is not owl's eye, because the one owl's eye picture that everyone has in mind is of RS cells, and those are two. That's a binucleate cell. Remember, it's owl's eye, not owl's eyes, right? You can see a single eye as well, and that here with the purplish inclusion is more in favor of CMV. When it is RS cell, the inclusions are eosinophilic. They're quite pink, very eosinophilic macronucleoli that you see, and of course a double nucleus, right? So please don't mistake these for RS, and before you even see it, you're going to have a history and you would have already figured out this could be an infection. Next, let's talk about herpes simplex virus, HSV. As I'm sure you know, there are two types, HSV1 and HSV2. Above the waist, below the waist, children, adults, etc., etc. Information I'm sure everybody knows. Now, lymphadenopathy of HSV is usually a rare diagnosis, but if you were to come across it, you would see an expanded paracortex again because it's a viral infection. But in addition, you can get necrosis and neutrophil infiltrate. Now, the three most important features of a cytopathic effect of HSV is what we call 3 M's. You will see this whether you do histo, you will see this whether you do cyto. Suppose you are looking at a pap smear from a patient with HSV, you'll see these same features. So these features are very important and very significant to identify HSV infection. You can also get a Cowdery type A eosinophilic intranuclear inclusions, but let's focus a little more on the 3 M's. This is the nucleus. This is the cell infected with HSV. You can see it's going to undergo multinucleation. So that's the first M. You look like the nuclei are molded together, and then the chromatin gets pushed to the periphery. So there's chromatin margination. So those are your 3 M's. Here is a photograph of the same. If you can make out, this is a cell affected. You can see 1, 2, 3, 4, 5, 6, 7 nuclei. You can see that they're sort of fitting together, molding together, and you can also make out that there's like an outline, and the central area is a little paler than the outline. So these are your 3 M's of HSV infection, right? Now a couple of more organisms and granulomas and necrosis. We're reaching the end of this presentation. Bartonella, the cat scratch disease. Remember, granulomas are present. It's a granulomatous condition, but more importantly, the granulomas are star-shaped. Necrosis is seen, and you'll also get follicular hyperplasia, tingible body macrophages because it's very rapid, lots of cells to die, and pink amorphous intracellular material. Next is Syphilis Triponema. Again, it is a granulomatous condition, but usually we don't see necrosis. As far as I'm sure all of you recall that syphilis also has a vascular component, so you get arteritis and phlebitis. They're like inflammation in the vessels is very common. So you'll get arteritis and phlebitis, and around the vessels you'll see a very rich lymphoplasmacytic infiltrate. TB, there's no end to what we can discuss about this. The granulomas are caseating, but please remember that you can get non-caseating granulomas as well, right, in TB. So caseating granulomas, over time you can see hyalinization and fibrosis, and please do not forget that lymphadenopathy in TB is the most common form of extrapulmonary TB that will come to you in practice. And finally, atypical mycobacterium. Remember, necrosis is usually absent, and it's a combination of suppurative and granulomatous inflammation. So it's not just purely granulomatous, you have a mixture. Now this photograph is from the same patient, it's the same case, but you can make out these are the lymphocytes, the normal lymphocytes, and here is an area you can see some fibrosis, and these are all a little bit organized, and this is pink area in between, and if I were to zoom in I could see some, giant cells. So this is a granuloma, which is a very bad attempt at being a star. Okay, look at that. So that's a stellate or a star-shaped granuloma seen in cat scratch disease. Now this is a more classical granuloma. As you can make out in the center, there is some necrosis. You can see some beautiful Langhans type giant cells, and all the dark dots that you see are the lymphocytes, which are more towards the periphery. And if you could see that there are some nuclei which are elongated, right? Can you make out? There are some nuclei that are elongated. These are the epithelioid cells. So very classical granuloma right here for you, a caseating TB granuloma with lymphocytes, Langhans type giant cells, central necrosis, and epithelioid histiocytes. So this was the part 1, and in the next part we're going to discuss inflammatory lymphadenopathy, where I'll talk about the 2 Ks and 1 C, the Kikuchi, Kimura, and Castleman. We're going to discuss neoplastic lymphadenopathy, where I'll give you algorithms for B cell lymphomas more importantly, and of course we'll discuss a bit of T cells as well. Metastatic lymphadenopathy, where I would discuss with you approach to carcinoma of unknown primary in terms of IHC, and then I will summarize everything. So just to recap, structure of lymph node in this video, the reactive patterns, and a couple of infections. So you can pause anywhere you want, you can go through the slides, you can take down the tables. I wanted to stress a little on the images as well so you can identify. I hope this was a useful video, and I hope you guys will look forward to the next one, in which we will have more interesting things to discuss about lymph node pathology. So please subscribe, like, and share the Pathodoodles page, and stay tuned for part 2. Thank you so much, and all the very best to everybody.